So my name is Jill Olmstead. I am a gastroenterology nurse practitioner here at Providence Health in Southern California. And the program that I'd like to go over with you today is going over the new guidelines for metabolic-associated steatotic liver disease, and now a new category that's called MetALD or metabolic-associated liver disease related to alcohol use disorder. So I want to thank GAP MASLD MASH Community Network for asking me to be one of their speakers. I've been a nurse practitioner in Southern California for over 20 years, and being a generalist in gastroenterology, sometimes it's a heavy weight to be able to have a lot of knowledge about a lot of different disease disorders, but certainly in our specialty in general gastroenterology, we've always seen a lot of patients with fatty liver disease. So what does that mean? You know, patients that have steatosis, fat in the liver. But over the last few years, the data that's been collected and the liver community in itself has really expanded the understanding of what goes into that disease state. So we have a case-based process today that I'm going to go over a case with you, hopefully to try to acquaint you with MASLD and MetALD. So these are the new guidelines that have been changed. And this has been not only a national, but an international community effort for the stakeholders in coming up with these different naming configurations for us to understand and really appreciate how complicated this disorder can be. So the case that I'm going to go over with you this afternoon, this is Ashley. She's a 52-year-old woman, and she's referred for an evaluation to gastroenterology, showing that her abdominal ultrasound shows that it's mildly enlarged and there's increased echogenicity in the liver. And this is a very common scenario of a patient that may be referred to my department in gastroenterology, or you as primary care may be referring this to a gastroenterology department. So we're going to walk through some different types of history and biomarkers that may provide you today with some additional information and a way to start working that patient up before you send the patient to gastroenterology. So her history, medical history, includes polycystic ovarian syndrome, hypertension, hyperlipidemia. Social history, averaged 2 glasses of wine per day. On physical exam, you notice that her abdomen is soft and that you can feel just the edge of her liver. And medications that she's taking is amlodipine, atorvastatin, a multivitamin, and milk thistle, because she had read that she heard that it was good for her liver and she wants to start taking care of her liver. So the patient information, we can see her vital signs. Her blood pressure is moderately controlled. Her weight is a BMI of 29.4, so we know that she's overweight. BMI guidelines, you want to encourage patients to be approximately 25. And then we also see that her liver enzymes are slightly elevated, as well as her alkaline phosphatase. Her total bilirubin's within adequate range. Her platelet count is within normal range, and her hemoglobin A1C is slightly elevated, and her triglycerides are slightly elevated. Now, keep an eye out. These are markers. These labs are your key labs in looking at the health of your patient's liver. Conversations will come into play now when I'll see a patient, referred for elevated liver enzymes. And if I notice that they do have hyperlipidemia and they're not controlled, say if they're in their 30s and they've had discussions with a primary care doctor that they want some more time to, get that lifestyle into shape, diet, exercise, so then there's no movement on that at all. So their lipids still creep up over the last 2 or 3 years. During my conversations with patients, and I will encourage them to follow up with their doctor to start having better control of that, especially if they're seeing me for steatosis or for fatty liver disease. Now, what's revolutionized the world of gastroenterology and hepatology is assessing fibrosis in the liver. Now, there are different markers to do that, or non-invasive testing ways to do that. So one of them is called a FIB-4 score, and that's a scoring system that you can just put in your Epic EMR system, look at FIB-4, and that will give you a percentage of the risk of liver fibrosis. Now, FibroScan really has revolutionized the gastroenterology and hepatology world. because it's prevented us from having to order as many liver biopsies as we used to. So the FibroScan is a non-invasive test, and it gives us 2 scoring markers. It's going to give us the kPa score, or kilopascals, and it's going to give us a CAP score. And depending on the range between those 2 scoring systems will give us the amount of fibrosis. So in our particular patient that we're referring to, her kilopascals is 11.4. So you can see that it's between the range of F3, which shows that she's significant fibrosis. And then her CAP score is 310. So that also shows that she has a severe amount of fat in the liver. Now, it's not uncommon when I'll see patients in my office for the first time and I'll order a FibroScan. Our algorithm is we order the FIB-4 score, and if it's over 2.0, then we'll order the FibroScan. So the FibroScan, if it shows that there is moderate to severe amount of fibrosis, moderate to severe amount of steatosis, but no fibrosis, I really give my patients, I cheerlead them and say, you have an opportunity to modify your lifestyle, lose weight, so we can prevent that fat from turning into fibrosis, because that's what happens. That's the natural history of once fat's in the liver, it can start to scar, and that scarring then can turn into fibrosis, which can then turn to cirrhosis. So this is the algorithm that the national and international thought leaders and the liver societies have now developed for us to follow in our gastroenterology department, or in the study of gastroenterology hepatology. So you can see the overarching banner at the top is steatotic liver disease. So that means there's fat in the liver. And how do we break that down? If you look to the left, my left, you can see there's metabolic-associated steatotic liver disease. That's called MASLD. And if there's more fat in it, then that breaks down to MASH. If you look in the middle, this is where the challenge is when you start marrying up MASLD or fat in the liver and alcohol intake, because the conversation that I'll have with patients in the office will always include their alcohol intake. And we don't do a good job to ask them if they say they don't drink alcohol. We don't always do a good job in asking them, well, beginning of the year, or would you say there was a time in your life when you didn't drink alcohol on a regular basis? So getting more of that past medical history of the alcohol use, because cumulatively, if a patient has had more alcohol, say just 1 year prior to you seeing them and starting your evaluation, that alcohol use can actually start that progression of the steatosis and then the fibrosis, even though they've abstained from alcohol, say 6 months before they're seeing you. So one of my key points is do a good job and ask them what their previous relationship was, or how much alcohol that they used prior. So weekly alcohol intake, you want to look at the graph here. And as far as per grams is the first line, but on the bottom is average daily alcohol intake per day. So if they're drinking, it's predominantly fatty liver disease or MASLD, if there's 20 to 30 grams a day. But you can see as you slide across, 30 grams, you're still in that mostly steatotic liver range. 40 grams, and then 50 to 60, then they're saying, well, then that's when you want to call it alcohol liver disease. And then looking over to the other side of your algorithm, you have just strictly alcohol liver disease. We see patients in our office that have a normal BMI, but their history is that they've had, 2 to 5 drinks per day for the last 30 years of their lives. Now, when you're working patients up with elevated liver enzymes, though, please be mindful to look at what are the other potential causes. You have drug-induced injury, or they call that DILI. You have autoimmune disorders. You have Wilson's disease. So if a patient presents to you with elevated liver enzymes, start with the basics. Make sure you're doing your complete workup. So with our case study, we're gonna have said that we've done our complete workup. We've looked for autoimmune disorders. We've done all that workup to make sure that that's been ruled out. Now, this is an important slide. So I mentioned that, I'll go back here. So I mentioned that 30 to 40 grams per day. That's right in the middle of where we really don't know which side of that scale we're on as far as, is it called MASLD or ALD? So if you look at these standard drinks here, so the equivalent of the standard drink, so 12 ounces of regular beer, or a glass of malt liquor, or a glass of wine, and you can go down the level here. This is how many grams of alcohol that are in your serving. So it's always important to ask the patient how much alcohol that they're actually in their serving. So the key pathogenic mechanisms of this dual etiology, it's complicated. So we've got the mechanisms of MASLD, which now the change is MASLD because it's metabolic-associated liver disease. So you've got the insulin resistant, you've got the diabetes, you have obesity, this visceral fat, sedentary lifestyle. With our case study, she has polycystic ovarian disease. Now this is a metabolic disorder. Patients who are creeping up on their hemoglobin A1C. But this is all metabolic associated. Now when you start looking at inflammatory, and now then when alcohol is involved, then we have the ethanol production and the lipopolysaccharides and this microbiome-derived products that causes this inflammatory cascade, which now is also accelerating the fibrosis and the disease progression. So drivers of liver disease, the higher the fibrosis, then it's going to increase your risk for liver decompensation. Now, there's a dynamic spectrum of this steatotic liver disease, because then you lay on the steatosis of the fat in the liver, then you start laying over the alcohol, and then you have on top of that the cardiovascular risk factors, and then potentially genetic risk. So there are some genetic markers that you're going to see those ordered in a research setting or in a university setting. We don't do the genetic risk factors in our department, but we certainly look at the alcohol use and document that. So you can see this spectrum, and patients don't always follow on a linear path, but what we do know is that the more fat that's in the liver, then the higher the risk of the fibrosis. Then adding on top of that, if patients don't lose weight and they continue to drink alcohol, it's going to potentially increase the risk more and more for liver fibrosis or cirrhosis. So detection of alcohol use with biomarkers. So there are some biomarkers that can be detected to see if there is alcohol consumption. It can be a basic questionnaire. And I've actually rethought my practice because I rely on the audit questionnaire to get my assessment for my patients. I think that there are some other questionnaires that we can use that may be more impactful for patients to let them know this is really important, they're serious about it, versus just asking them how much they usually drink. Studies show that patients will underestimate how much they drink, so we have to be mindful of that as well. So the moderate to excess alcohol consumption is going to be, it's documented that it's in almost 30% of MASLD patients, and then 25% in MASLD patients. Now, with the new naming configuration, both terms are synonymous, but they're applying data that was collected previous then to this newer definition. And then optimal diagnostic means are looking at the audit scores that we get for patients, as well as the hair samples, but you're not seeing that done. Again, in a community practice, we don't do that. So there are gaps in the assessment of it, right? In really understanding the MetALD. So those gaps are, number one, the evidence of the metabolic dysfunction. This is more quantitative. So we can measure BMI, we can measure serum glucose, we can look at the blood pressure, we can look at the triglycerides and the HDL. And I am definitely making more efforts in my documentation to identify these metabolic dysfunction. The challenging part from a general gastroenterology practice is that we're picking up these markers that really are the ownership of primary care, yet you see metabolic dysfunction starting to be owned more by gastroenterology. So the community of primary care physicians and providers that I work with are amazing, and I'll send notes just to encourage them. You know, patients has hepatic steatosis. You know, this is the fibrosis score that we've done. You know, encourage patients to improve their blood pressure management and improve their lipid profile. So we've definitely worked together. I think the other gap really is what I had just mentioned, is this assessment of alcohol use. You know, really looking at quantifying that alcohol in grams per week, you know, estimating what that local standard drink definition is for, but asking them, you know, what is your drinking pattern? Is this daily or binge drinking? So if patients are not drinking every day and then they're only drinking on the weekend, then quantify that as well. Usually patients say, oh, I don't drink that much or don't drink regularly. I just take the time to ask them, you know, how much is it that you're drinking either per day or per week? Usually I'll start off with a per week, but then if it's a daily basis, then I just ask them how many per day. And then alcohol use, we want to look at how many grams per week to use that patients can use. And then depending on the amount of grams that patients use per week will then help guide you, is this metabolic-associated alcohol liver disease, or is this alcohol-associated liver disease? And you want to look at the isolated hypertension and hypertriglyceridemia, which I had mentioned. You want to make sure that we're picking up for those cardiovascular risk factors that are going to be impacting the metabolic dysfunction. And then again, using alcohol biomarkers. So currently in our current practice, we do not use alcohol biomarkers, but my other colleagues at the university centers are using a PEth test, which is able to pick up if patients are using alcohol within a recent time period. These, what we usually do is, the PEth test is recommended for patients who I think are more, you're looking at patients who are abstaining from alcohol. So you're looking at the patient that is having problems with the MetALD patients, but also that you're trying to assess if there's abstinence. So some practices will order this test within that initial workup. Some will look at it and order it after, say, that next follow-up visit. So with our case study, you know, the patient, her value for the PEth test, so it was performed with this workup, was 120 for our particular patient. So the PEth test, the range is 20 to 200, and the definition of that is moderate to heavy alcohol consumption. So from their history that they told us, they're drinking more than what they shared with us. So I believe it's important to share that you are doing this test with your patients. I have heard of a read before that some clinics will order the test, but not exactly explain to the patient what it's for. But I think it's important that we're open with what we're testing and what we're looking for. So alcohol, or the phosphodialide ethanol is detectable for 3 to 12 days after one single binge, meaning that there's a half-life time of 3 days. And no significant variability by sex or BMI. That's why this test has been studied, for its specificity and reliability. So alcohol use in individuals with excess weight. This is a study where 659 were screened for the study, and they looked at never drinkers or missing data, and they studied females and males, and 97 of them were analyzed were suspected with MetALD. And what they found was that there was a 16% at risk for developing MetALD based on their alcohol use screening. So with our particular patient, the case study that we've been going over, I think it's important to identify that there is a metabolic disorder history. So she has polycystic ovarian syndrome, she has hypertension and hyperlipidemia. And we've already identified that our patient could actually be better controlled. These next few slides, are going to illustrate the importance of how alcohol affects other metabolic disorders. And I think, when I give this presentation, it's important to realize that I'm speaking to other colleagues and peers that understand the link to the damage that alcohol can do to our systems. I think the hard part is having that conversation with our patients in the office, because we know that alcohol use disorders, or alcohol use, even whether it's social, patients don't perceive that they have a problem, or that is it a problem that could be affecting them. And especially when we hear vernacular like, well, I only have one drink at night, or I only have a couple drinks on the weekend. We don't want to be judgmental when we're getting a history from patients, but at times I will say that, alcohol actually is hepatotoxic. It causes toxicity in our liver, and it's our liver's job to clear that. And there's no nutritional value in drinking alcohol. So as I mentioned, alcohol can, has a biphasic effect on blood pressure. It decreases it for the first 12 hours after consumption, but then it increases it 13 hours after that. So if our patients have hypertension, maybe this is some additional information that we can give them clinically to help develop that business case of why we want patients to stop drinking. And in addition, the relationship between alcohol and hypertriglyceridemia, the mean plasma triglyceride concentration is over 10 hours after administration of just 2 standard drinks. So again, there's no safe amount of alcohol to use. This is what I describe to my patients, especially when it can affect other parameters of your health history. So in our case, as we go back to our 52-year-old woman, remember, it all started when referred to GI department because she has an abdominal sonogram. It shows mild hepatomegaly and steatosis. But she feels well without any complaints. So we're rocking her boat by investigating all these other parameters and really bringing these different key points in with her on the risk that's happening right now in her body, and that how she needs to start making some changes, or else she's going to start developing some worsening of her liver health. And sometimes I'll use those terminologies. I'll talk to her about, these are recommendations I'm making for you to improve the health of the liver. So we talked about the laboratory data. We talked about the medication she's on that tells us that, the different disorders that she has. Remember, she had 2 glasses of wine per day. And we have the parameters. And we also, we did a FibroScan. We ordered that, brought it back in. And we see that the liver fibrosis score. So she has high amount of fibrosis and steatosis, or fat in the liver. So the diagnosis of this patient with these parameters would be MASLD, with predominantly MetALD, or metabolic alcohol liver disease. So questions to answer for this particular patient are, what are the current treatments that we can offer her? So really, the discussion is to start with is weight loss. I mean, weight loss can reverse the steatosis in the liver, as well as reverse the fibrosis. So I really spend time explaining to patients that this can make a big difference for them by starting by losing weight. Studies show that any diet that you follow will start to make a difference. And also I take emphasis off of exercise and just start asking my patients to start counting their calories. Usually patients don't know what a calorie is. I ask them, okay, let's just collect some data. Don't start a diet. Don't make any lifestyle changes, but I want you to start collecting data. And so one app that I use is called Lose It. I ask patients to download it. And it's a free app, and they can just start tracking how much that they eat, breakfast, lunch, and dinner. There are a lot of barriers that you're going to encounter when you start to address this issue with weight loss with patients. So I always take exercise off the table for them and just say, let's collect data to see what you're doing and where opportunities are. So this particular patient, because she had a fibrosis score of F2 to F3, she would be a candidate for Resmetirom, which is called Rezdiffra, which is the first PPAR agonist that is able to actually reverse the fibrosis in the liver. So they can transition from fibrosis into start to reverse the steatosis and the fibrosis. The challenge is that some patients don't respond to it, and it's the FDA guidelines recommended that this medication is to be paired with weight loss. So it still comes back to weight loss to be able to try to make an improvement for patients. And then what are our recommendations for alcohol use? Well, we need her to stop drinking, period. These are the difficult conversations, because patients, she came into your office feeling fine and not under the perception that she had a problem. So definitely you have to talk to her about making sure that you're discontinue alcohol, which is causing the insult to the liver, which is why you have the liver enzymes also that are elevated. And then does she need hepatocellular carcinoma screening? Yes, because she has fibrosis in the liver. So she would be someone that she would be put in our routine screening program. So it's every 6 months that patients would have an abdominal ultrasound and then an alpha-fetoprotein to look for hepatocellular carcinoma. So patients need these conversations that because of the steatosis and mostly the fibrosis in the liver, you're at risk for developing hepatocellular carcinoma. It's important to get a family history on these patients too, because it's not uncommon that you may find that there is liver cirrhosis in their family, or a patient has been identified with hepatocellular carcinoma. Some of my patients will say that, well, you know, my uncle or my father drank, you know, I don't drink that much, so I don't think I'm going to have liver cirrhosis. But you can see now what's happened, you know, over the last 10 years is we're finding that it's the steatosis or the fat in the liver being overweight that actually is driving the fibrosis or the liver cirrhosis of the liver. So we need more data, right? So the ideal MetALD definition for clinical trials is going to be looking at those objective biomarkers. You want to overcome the underreported of alcohol use. You want to standardize the assessment use of alcohol and to certify if there's alcohol abstinence. And you want to ensure that drivers of the liver disease are present. So look at those one or more cardiovascular risk factors and ensure that if there's persistence of hypertension or hyperlipidemia, then to stop the alcohol use. And then you want to consider exposure to risk factors, fulfillment of criteria during the last 6 to 12 months. So those take-home messages. New definition of MetALD is that alcohol intake is beyond 140 to 35 grams per day or per week, and 210 to 420 grams per week for women and men, respectively. So the first one was per day, and then the second one is per week. Then the critical alcohol criteria could underestimate MetALD, also ALD. So encouraging the wider use of alcohol biomarkers or the PEth test, and ensure that drivers of the liver disease are present. Reassessment of the metabolic dysfunction over time, and then consider adequate exposure to risk factors. And then also criteria for clinical research should facilitate an objective MetALD diagnosis, looking at comparisons, especially among sociocultural realities. And this is a new definition, so the researchers and the national societies are looking at ways to get more data, but you can see how it overlaps between the steatosis with the alcohol use. And I had even mentioned that some people who have had alcohol use in the past, say a year prior, but then they've been abstinent for a year, they don't know how that can potentially still be crossing over into the diagnosis or carrying over in the diagnosis for today. So this is your QR code. Please make sure that you use this this is to visit the community network for any additional disease state education, and also the Rezdiffra webcast.